Haloperidol is an antipsychotic D2 receptor antagonist. Haloperidol is available in both tablet and injection formulations. The structure of this drug follows Lipinski's rule, making it ideal for oral administration. Its molecular weight is less than 500. The log P value indicates it's lipophilic enough to get through into biological membranes. It has 6 rotatable bonds and a polar surface area of 40.5. Haloperidol can form hydrogen bonds. As you can see outlined on the structure, it has 4 hydrogen bond acceptors and 1 hydrogen bond donor. All of the properties outlined demonstrates that it has excellent oral bioavailability. How was haloperidol discovered? Haloperidol was discovered by Paul Janssen, founder of Janssen Pharmaceuticals in Belgium. The company developed the drug in 1958 and it was entered for clinical trials later in the year. The company was looking for analgesics with properties similar to morphine. Research started with pethidine, which was also being researched by British chemists for its analgesic property. Janssen's group then substituted the methyl on the nitrogen in the pethidine with the propionophenone group to form phenoperidine. This was found to be 100 times more potent than pethidine. Numerous analogues of phenoperidine were then made to try and further improve the analgesic properties. To try and get around patents, the decision was made to change the propionophenone with a butyrophenone group. This would then extend the chain between the nitrogen and the aromatic ring. This gave the analogue, which was then named R1187. This molecule had short-lived analgesic effects, but also notably cataleptic effects, for example, lack of response to external stimuli, muscle rigidity, and decreased sensitivity to pain. This reminded Janssen of chlorpromazine, an existing neuroleptic. Numerous derivatives of this analogue were made to try and increase the neuroleptic action but decrease the morphine-like activity. One of the derivatives synthesized was haloperidol. This was named haloperidol because of the 2 halogen substituents. In clinical tests, haloperidol was found to have 50 times more potent neuroleptic effects than chlorpromazine. Haloperidol was the first of the butyrophenone class of antipsychotics. This is now a very important class of drugs which includes some of the most potent and commonly used antipsychotics on the European market. How was haloperidol developed into a drug? The first human clinical trials of haloperidol started in 1958. It was given to psychiatric patients using intravenous administration and was found to be a very effective sedative to control psychomotor function. It has a very rapid onset and a 3 to 5 hour duration of effect. During clinical trials, haloperidol produced side effects including akinesia, which meant the patients were experiencing loss of voluntary movement, rigidity of muscles due to hypotonia, and the loss of the ability to act decisively. Following clinical trials, it was decided that haloperidol was the best drug available for treating manic patients. It was found in studies with chronic schizophrenia patients that small doses of around 2 to 5 milligrams displayed excellent results without any of the serious Parkinson-like side effects associated with haloperidol. The development of this drug proved that it was a very useful drug to enter the market, and shortly after this, a synthesis route was developed in order to allow for the mass production of haloperidol. So how exactly is haloperidol synthesized? The first step is the addition of an amine protecting group, carboxybenzyl, which is denoted as CBZ in the following synthesis. After this, a Grignard reaction is carried out to produce a piperidine intermediate. Following that reaction, the protecting group is removed in the presence of palladium on carbon and hydrogen gas. The second step is the Friedel-Crafts acylation of fluorobenzene using 4-chlorobutyric acid chloride in the presence of aluminium chloride. In this reaction, 4-chloro-4-fluorobutyrophenone is produced. The final step is the amine alkylation between the piperidine intermediate and the product formed in step 2 of the synthesis, in the presence of potassium iodide and toluene. After this, our final product haloperidol is produced. So what exactly is haloperidol used for? As briefly mentioned above and demonstrated by the clinical trials, it's used for the treatment of manic disorder and schizophrenia. Schizophrenia is considered to be a neurodevelopmental disorder. This implies that structural and functional changes in the brain are present in the uterus in some patients, or that, more commonly, they develop during early stages of life. Symptoms include becoming socially withdrawn, and generally unresponsive to social interaction. This is often coupled with changes in sleeping patterns. Schizophrenia manifests itself in episodes which can be shown by distinct changes in behaviour, such as hallucinations and lack of emotions. Psychosis is a mental health disorder that causes people to interpret things differently from those around them. It's also a general umbrella term for a variety of mental health disorders, including the presence of delusions. The dopamine hypothesis for schizophrenia is a model linking schizophrenia and associated psychiatric disorders to an overactive signal transduction of dopamine in the brain. Dopamine binds to D2 receptors in the limbic system of the brain, causing effects such as hyperactivity and hallucinations when it's overactive. This is especially important when looking at the mechanism of action for antipsychotic drugs such as haloperidol. So how does haloperidol work? Haloperidol competitively blocks postsynaptic dopamine D2 receptors in the mesolimbic system of the brain. This eliminates dopamine neurotransmission and leads to anti-delusionary and anti-hallucinogenic effects. The antagonistic activity is mediated through the D2 dopamine receptors in the CTZ, or chemoreceptive trigger zone, in the brain. This is what accounts for its antiemetic activity. Haloperidol not only works on the D2 dopamine receptor as an antagonist, but also the glutamate receptor and 2 other dopamine receptors. Outlined on the screen are some of the most common side effects experienced by users of haloperidol. These side effects occur due to, as mentioned before, its antagonistic and inverse agonist properties on other receptors in the brain. Haloperidol can also be an antagonist for antihypertensive drugs, which can lead to some unwanted side effects of increasing hypotension with antihypertensives and enhancing the QT prolonging effect of certain agents. When considering a drug antagonist, such as haloperidol, it may be useful to overlay the drug with its natural ligand it's antagonising to see if we can identify a pharmacophore. In the case of haloperidol, it bears no real resemblance to dopamine or serotonin. So how does it work? Unfortunately, little is known as to the detail of how the molecule binds, but we can go through the essential structural features that give haloperidol its high neuroleptic activity. Haloperidol is known as a butyrophenone. Here is the basic structure of a butyrophenone. To give the molecule its high neuroleptic activity, a few modifications need to be made to this original structure. The first modification is at this point, the halogen fluorine is added to the benzene ring. And at this point, an amine is added to the carbon chain. The result of these additions forms the basis of haloperidol. The fluorine substituent is very important, as it has been found that the most potent butyrophenones have fluorine attached at the para position of the benzene ring. The tertiary amine added in this position is also essential for neuroleptic activity. The propyl chain length, as shown here, is optimum for activity. Any lengthening or shortening of the chain has negative effects on the activity. To emphasise the importance of the structure-activity relationship, here are 2 other molecules with high neuroleptic activity. We can clearly see that all 3 of them share the 3 features mentioned previously. In addition to the use of oral haloperidol, another prodrug version, called haloperidol decanoate, was introduced as depot maintenance therapy. When injected every 4 to 6 weeks, the drug appears to be as effective as daily orally administered haloperidol. Haloperidol decanoate is synthesized by the esterification of haloperidol with decanoic acid. The drug is injected via the deep intramuscular route. This type of administration allows for gradual release of the haloperidol decanoate, which is then hydrolyzed in the body into free haloperidol. This slow and sustained release of the drug is highly beneficial for patients who have trouble remembering to take their medication. To conclude, haloperidol is an antipsychotic D2 receptor agonist. Its most common indications are manic disorder and schizophrenia. The mechanism of action for the drug is not entirely known, however, the currently accepted theory is the dopamine theory. Hopefully this video has been informative, but if you'd like to know more, please feel free to follow our references or use the links on the screen. Thank you for listening.